Our first speaker is Dr. Ana Diez-Roux. Dr. Diez-Roux is Dean and Distinguished University Professor of Epidemiology at the Dornsey School of Public Health at Drexel University. Welcome, Dr. Diez-Roux.
Thank you. Good morning, everyone. I'm going to share my slides here. So good morning. It's my pleasure to be with this roundtable. I was able to listen into the earlier session and very much enjoyed it. So thank you for having me. So I'm going to talk a little bit about the role of complex systems approaches in population health, and in particular in understanding the impact of environmental factors on health, and specifically neighborhood characteristics. I have no conflicts to disclose. I don't need to tell this group about why we focus on neighborhoods in public health. Some of the reasons are listed here. I just want to highlight particularly that because we have a very strong segregation by race and by income in our society, neighborhood differences may be very important contributors to health inequities and have major public health and policy relevance. So they've gotten a lot of attention. At the same time, identifying the causal effects of neighborhoods has sometimes been complex. And this is because the factors that drive neighborhood differences in health are many. On this slide, there are the two key ones that are most often talked about. Certainly the top one, the idea that health is affected by features of the neighborhood. For example, availability of places to be physically active may promote physical activity. And also people end up being sorted into neighborhoods based on individual attributes as a result of their opportunities, their income, also racism. And a lot of the traditional empirical work on neighborhoods and health has really focused on trying to separate out these two things so that we can identify the impact of the process listed at the top, which would be a causal effect of neighborhoods on health. But in reality, it's a lot more complicated than that. Some people, not everyone, but some people may be more able to select where they live based on preferences for certain attributes. People may also change their behavior in response to the behavior of other people around them. This is very much connected to the social network conversation we were having earlier. And neighborhoods themselves can change in response to what's happening to the behavior of residents and to the perceptions of other agents. For example, the predisposition of businesses to locate in certain kinds of neighborhoods. So this means that in reality, these neighborhood patterns emerge from the functioning of a system in which individuals interact with their environment, they interact with each other, and individuals and environments adapt and change over time. Neighborhoods also affect each other. For this reason, there's been a lot of interest in applying the tools of complex systems modeling, in particular agent-based models, to neighborhood effects research. And some of the reasons why this has motivated, why this particular substantive area has generated, interest in applying these kinds of methods is precisely because of this bidirectional person-environment relation that's likely going on, which is sometimes referred to as selection, which is, is much more complicated than just selection, obviously, because we want to understand selection, not just control for it. And this idea of endogeneity because of these feedbacks that are happening. Also, of course, there are interactions between people, networks, norms, as we heard earlier today. Physical and social environments affect each other. So although we try to isolate them in our traditional regression analyses, they're really mutually influencing each other. The presence of a park may affect safety. Safety may affect the way the physical environment evolves, for example. And as a result, and there's also strong segregation of both individual and environmental characteristics. So for all these reasons, these kinds of questions are particularly suited to sort of systemic approaches. And I'm just going to very quickly give you an example. This is a paper led by my colleague, Amy Auchincloss. This is a number of years old, but I think it's a useful example, particularly also because of the interests of this roundtable. And it focused on applying an agent-based model to try to understand some of the drivers of income inequalities in diet. So we know that income differences in diet are well established and may contribute to health disparities. We know that there's spatial segregation of healthy food access, but despite that, and despite empirical research in this area, there's been a lot of questions still regarding, well, how important is this causally? and what are the policy implications? And so we developed this model to address two exploratory questions. One is a very simple question, which is basically, does spatial segregation contribute to income disparities in diet, absent price or preference differentials? Because a lot of the counter arguments to the neighborhood effects literature is, well, neighborhoods are just offering what people want. So let's suppose we had a world where we could eliminate differences in preferences, we could eliminate differences in price. Just would the spatial segregation of stores, because some stores just do not locate in poor or minority neighborhoods, would that in itself potentially be sufficient to generate income inequalities in diet? And then in a second stage, how could we manipulate price and preference in the context of segregation and to what extent would we see an impact of disparities? So I don't have time to get into the details of this, but basically this model has two types of agents, households and stores. They each have attributes and they behave in certain ways. People shop, stores react to how many people are shopping, etc. So we basically use this model to address our first question, compare income differentials under various spatial segregation scenarios, assuming constant price of food, so no differences between healthy and unhealthy foods in price, and constant preferences. And then we compared income differentials holding segregation constant, but varying price and preferences. So we basically tested out different hypothetical segregation scenarios in which we had, low-income people clustered with unhealthy stores or vice versa, all the different possibilities to see under which scenario income differences comparable to what we see in the real world in diet emerged. And I can't get into the details of this, but we found essentially that scenario 6, which is the most realistic scenario in terms of segregation, where low-income households were clustered with unhealthy food stores and high-income households were clustered with healthy food stores, that was the scenario where we saw income differences such that higher income people had healthier diets than lower income people emerge very clearly, and not in the other segregation scenarios. So we concluded from this, as a sort of proof of principle exercise, income differentials emerge in the presence of co-segregation of low income and unhealthy stores, even when food preference and price are held constant. So then we said, well, what happens next if we manipulate price and preferences? So we had our reference scenario, which is the segregation scenario that I just showed you on the left, and then we tried hypothetical intervention. So let's assume we did a terrific health education campaign and we convinced everyone to prefer healthy food. Well, it turns out that the income differences did not disappear. The education campaign was not enough to overcome the spatial inequities. Then we tried price. What if we made healthy foods much cheaper than unhealthy foods? And what we found, interestingly, when we made healthy foods cheap and unhealthy foods expensive, that the difference actually flipped, such that low-income households had better diet than high-income households. And this happened because, and this is something we saw in the model that we might not have predicted before, that this was because the expensive unhealthy stores closed in the poor neighborhoods, and that increased access to healthy foods in the poor neighborhoods. And then we tried combinations of various strategies, which I won't get into, but if you're interested, I have the citation to the paper. So the bottom line is, what did we learn from this modeling exercise? Well, we learned that segregation can create disparities in diet, even in the presence of no differences in preference or price. We saw that changing preferences is not enough. We saw that price manipulation seems to have a stronger impact than preference manipulation, but price and preferences reinforce each other. Most importantly, this exercise really forced us to think about the processes. And I think this is really important and connected to some of the conversations in the earlier panel, because it really forces us not to think about, let's separate out this effect from that effect, but it really forces us to think about and hypothesize what processes are going on that might be generating the patterns. And also, in doing this, we realized how much we do not know, and it generated a lot of ideas for new data collection and new empirical studies to address some of the gaps that we identified as we were trying to develop this model. So I think just to reinforce, I think one of the benefits of these systems modeling approaches is that it really forces us as investigators, as researchers, to develop these more dynamic conceptual models that think about processes. Sometimes in our, in sort of our empirical research, we start to get a bit lazy and we start to, focus in, as I was saying earlier, in separating independent effects, when the real world is not about independent effects, it's about processes and dynamics. In developing these dynamic conceptual models, we can also incorporate the input of stakeholders, which I'll return to in a couple of minutes. So the modeling itself is a very useful tool. You can gain often insight. You can do thought experiments in the context of these dynamic relations. Sometimes you can identify interventions that you hadn't thought of before. And it's an interesting way to integrate different kinds of data. So you can sort of put together different kinds of data, both quantitative and qualitative data, and try to see the implications of that when it sort of comes together, and also identify gaps in data needs. But there are also a number of important caveats. Keeping it simple but relevant. It's really critical in these models, if they're going to be informative, to set bounds on them. And that is a decision, what we include and what we don't include. The beauty of this is that it's very explicit, what we include and what we don't include, and other people can see it. Another big caveat is assumptions. These models require a lot of data. They have a number of assumptions. And sometimes it can be challenging to have the data to support those assumptions or to validate the models. However, they do make these assumptions very transparent. It's an arduous process. Anyone who's done it knows this. And transparency and communication about these models can sometimes be a challenge. Replication, for example, as well. And last but not least, well, when does it make a difference? When do we learn something from the modeling? And it's not we get out of the modeling what we put into it. This is a really important point that I think we have to think very carefully about when we apply systems approaches. An interesting aspect of these models, as I alluded to earlier, is that it really forces you to think of the questions a little differently. And I think this, more than anything else, more than the sophisticated modeling, is probably the greatest value of this kind of approach. So from a question like, are neighborhood characteristics independently associated with health after accounting for individual level SES? An important question, I think, that many of us have worked on, but a limited question in some ways too, to a question that's more like, to what extent and under what conditions could residential segregation generate and reinforce health disparities by race? So you see a much more nuanced question, a much more policy relevant question. Or another example, is proximity to supermarkets associated with better diet after adjustment for individual level SES? Or in contrast, what is the plausible impact on health inequalities of a strategy to subsidize the location of supermarkets under various spatial segregation scenarios? So really, I think we should think of systems modeling as part of the toolkit that we have that includes observation, that includes experimentation, and that also includes action and the evaluation of action. So it's really, and these methods should reinforce and feed into each other. And I think to get a full understanding of the processes that we're studying, I think we have to figure out ways to combine these approaches more and use them to sort of quadrangulate across these different methodologies. And to finish up, I wanted to share with you one recent study that we have where we are trying to do exactly this. This is the Salud Urbana study, Salud Urbana in America Latina. It's a study on urban health in Latin America, funded by the Wellcome Trust, focused on urban environments and health equity. And we have 4 aims: observational aim, policy evaluation, sort of natural experiment aim, a systems aim, and a policymaker engagement aim. And the systems aim has 2 pieces to it. One is a participatory systems approach, participatory group model building, which is a really wonderful tool that is formalized, and there's literature on it, where we engage multiple stakeholders in in building these systems maps of a particular problem or process that they're dealing with. And these maps are informed by their lived experience, by their professional background, by their own information, the information that they have, whatever their work or experience is. And through these approaches, the group comes up with a causal loop diagram, which highlights, in this case, that this is an actual systems map that one of the groups came up with. We did this with stakeholders in the Latin American region. They were focused on active transport and thinking about what different kinds of factors affected active transport, and then also identify in the yellow dots some potential interventions and how they might work. So this was a fascinating exercise. The participants also go away with new tools that they can then apply in their own day-to-day activities. And this stakeholder engaged systems mapping is one of the inputs into subsequent agent-based modeling that we're doing to understand the impact of various policies on active transport and consumption of processed foods. So I'll stop there, and I'll end with a quote from Roux, who is one of my favorite epidemiologists. He did not write very much, but wrote a really nice little jewels, actually. If we consider disease to be embedded in a complex network in which biologic, social, and physical factors all interact, then we are impelled to develop new models and adopt different analytic methods. And I think this is why the systems approach is so interesting and intriguing to many of us in population health. Thank you very much.